We are all familiar with the term syncope. What is syncope? Syncope is transient loss of consciousness due to decreased cerebral perfusion. And what is a natural history or how this occurs? The typical example is a patient standing for a long time in a queue, in a church, or somewhere. Say prolonged standing, and there may be some stress also. For example, somebody going to the reception hall for the first time, standing for a long time, there is some amount of anxiety or fear or stress will be there. Suddenly develop darkening of eyes, graying of vision, and falls to the ground. Within few seconds, you regain consciousness, you are aware of what has happened, and you are completely normal. And this is the typical history of a syncope. So, what are the features? The features are one, it is transient. Second, there is loss of consciousness. There is loss of muscle tone. And there is a spontaneous recovery without any intervention you have occurred. And the mechanism is decreased cerebral perfusion. Now, let us look into what are the major causes for syncope. This can be basically divided into three. One is reflex syncope, second is cardiogenic syncope, third is orthostatic. So now look into what do you mean by the reflex syncope. Reflex syncope is a neurologically mediated syncope. So typical example is the vasovagal syncope. Second is situational syncope. Situational syncope means suppose somebody develops a loss of consciousness during micturition. This is called micturition syncope. Or somebody has a bout of cough and they develop loss of consciousness. It is called as cough syncope. These are two examples of situational syncope. Third is carotid sinus syncope. So suppose you have got a hypersensitive carotid sinus, especially elderly, when they turn the head or go look backwards, a tight collar may press on the carotid sinus and this can activate the carotid sinus and can probably lead on to syncope. And in these situations, basically two things can happen. One is there is a cardio inhibition, that is, there is excessive vagal activity leads on to bradycardia. Second is there is a vasodepressor effect because the adrenergic support is producing vasospasm, and when the adrenergic support is lost, you get a vasodilatation. So the basic problem that occurs in vasovagal syncope is there is a cardio inhibition and vasodepression. And how this occurs? And this is the exact cause is not sure, but again the hypothesis is that when there is a when the patient is standing for a long time or when there is a trigger like the seeing blood etc., there is some amount of the activation of the stress receptors in the ventricle occurs, especially when the volume of the ventricle is decreased. So this contraction or stress on the stretch receptors will activate the baroreceptors. This leads on to inhibition of the sympathetic supply and facilitation of the parasympathetic outflow. That is the reason for the bradycardia and vasodilation. That is cardio inhibition and vasodepressor action that is occurring in most of the case of the neurally mediated syncopes. Hope this point is clear. Now we go into the second important group. It is the cardiogenic syncope. In cardiogenic syncope, there is a cardiac cause, and most of the syncope, even we have said it is a transient loss of consciousness, it has got a preceding. Some prodromal symptoms will be there like lightheadedness, darkening of eyes occurring in both eyes, sweating, so palpitation. So some premonitory symptom will be there. In cardiogenic syncope, there is no such features. It occurs abruptly, and a classical example is a patient developing complete heart block. Or this can be due to tachyarrhythmias or any bradyarrhythmias can occur. Cardiac syncope has got a bad prognosis. And as mentioned, most often there can be some structural heart disease also. That is a patient with myocardial infarction or a patient with a cardiomyopathy. Another example of cardiogenic syncope is occurring when there is an obstructive lesion like aortic stenosis, pulmonary stenosis, or a pulmonary arterial hypertension. These patients can develop a syncope, especially on exertion. So, cardiogenic syncope is different from other types of syncope in that it is can occur in any position. Because somebody lying down, they can develop a arrhythmia and develop a syncope. But most often, other cases, that is reflex syncope and the orthostatic syncope occurs only in the standing position. Again, remember pulmonary embolism that can also lead on to can be considered as a cardio or a cardiac etiology is also there in acute pulmonary embolism. Then now going to the orthostatic. So when you stand, what happens around 500 to 800 ml of blood is pooled in the venous system. This will lead on to reduction in the blood pressure, and the immediate rescue is by the neurally mediated, that is a baroreceptor activity. Once this is failing, then you can develop that is the baroreceptors are stretch receptors. Once they are activated, that is when the BP is high, what happens? This will lead on to inhibition of the sympathetic supply and facilitation of the parasympathetic outflow. And when the BP is low, there is activation of the sympathetic activity and inhibition of the parasympathetic activity. If there is some cause for this autonomic reflex is not there, that can lead on to orthostatic syncope. So somebody has got a significant loss of volume, hypolemia, following a trauma, there is blood loss. Such a patient on standing up, they can develop a syncope because the baroreceptor will not be able to save the patient. Another example is somebody with a severe dehydration due to diarrhea. That patient can also develop on standing, they can develop or somebody has got upper GI bleed that they might not have noted because it might have occurred in the early morning in the toilet. The patient might have passed a lot of blood, and then they stand up, they may develop a syncope in the toilet. So these are the examples of orthostatic syncope. Orthostatic syncope can be due to autonomic failure. For example, a patient with Parkinsonism or multi-system atrophy, there is a dysfunction of the sympathetic system or the autonomic nervous system, and the baroreceptor activity will not be there. So this can lead on to. Second important condition is a diabetic autonomic neuropathy. So again, such patients on standing, there will be significant BP fall. That is a baroreceptor activity or the sympathetic activity will not be able to support the reduction in the blood pressure. Then alcoholic patients. So diabetes is one of the important conditions that you consider when somebody says that they want standing up, that they develop dizziness. Then any condition that produces volume loss, which I already mentioned, most important, remember drugs. Beta blockers, alpha blockers. These are notorious to produce postural hypertension, antipsychotics, antidepressants. So anybody developing dizziness, postural dizziness, always think about or take a history of medications. How will you diagnose orthostatic hypertension? Ask the patient to take the blood pressure in the lying down position. Ask the patient to stand up, and during the first 3 minutes, it record the blood pressure. And if the systolic BP falls more than 20 millimeters and diastolic BP falls more than 10 millimeters, we can say that the patient has got a significant orthostasis. And it is always a good habit to record the pulse rate. Most often, with the postural fall, the pulse rate increases. And it is a very common thing to see that when somebody has got a febrile illness, after some recovering from the fever, many patients may complain of dizziness on standing or walking. The BP may be normal on the standing position, but there is tachycardia. The pulse rate increases. This is called POTS, postural orthostatic tachycardia syndrome. This should also be kept in mind. Then what are the differential diagnoses? The most important condition is the seizure. Often it is difficult to differentiate between seizure and syncope. We will come to that. Second is vertebrobasilar insufficiency. This can again produce a transient loss of consciousness, subclavian artery stenosis. Alcoholic patient taking alcohol, they can develop blackouts. Another condition, a rare thing, is the cataplexy with emotion. The patient may develop postural tone and fall to the ground. It's cataplexy and psychogenic causes. The details will be discussed later. The most important thing to differentiate, how to differentiate a seizure from syncope. And as already mentioned, seizure usually so abrupt. There is no warning symptoms, and the patient falls down and can develop a significant injury. In a patient, syncope can also develop an injury like a Colles fracture because they are trying to fall and protect themselves. They can develop a Colles fracture, but a head injury is very unlikely to with a syncope. Tongue bite is an important symptom you should keep in mind. So tongue bite, especially on the lateral aspect, is very suggestive of a seizure. Duration of the syncope is transient, only minutes. In a patient with a seizure, this can be over minutes and can have tonic-clonic or jerks will be there. In seizures, the jerks occur first, or the early is the jerks. In syncope, very rarely you can get what is called convulsive syncope. They develop a syncope when the patient doesn't recover. There will be continuing ischemia going to a brain, and that may produce a seizure, convulsion. So convulsions in syncope is a late manifestation, whereas in seizure it is usually the early manifestation. Postictal confusion is very common in a seizure. If at all it occurs in syncope, it is transient and the patient will recover as if they get up from sleep. Then incontinence. Incontinence is common in seizure, very uncommon, very rare in a case with the syncope. Then look at the eye deviation. There is a eyes moving to one side is horizontally is more in favor of a seizure. Some eye movement can occur in syncope, but usually it is some vertical movement. And already we have mentioned about the prodromal symptoms. Aura can occur in seizure. In syncope, there will be the prodromal symptoms will be different, like dizziness. By taking a proper history, most often you will be able to differentiate between seizure and syncope. Now looking at the prognosis. As already mentioned, cardiogenic syncope has got a bad prognosis. So if the ECG is abnormal, like changes of myocardial infarction, it is a bad prognostic sign. Patient has got features of heart failure on examination, significant symptoms like dyspnea, blood pressure is low, hematocrit is low, age is more than 65. These are some points you can think that the syncope has got a bad prognosis. How will you evaluate? Most of the investigation is a syncope. Any patient coming with a syncope should have a proper history and a good physical examination. Always check for orthostasis. This is very useful. All patients should have an electrocardiogram. ECG is taken to look for features of ischemia. Second is to see whether the patient has got any conduction block, first degree, second degree or third degree heart block, WPW syndrome, long QT syndromes. These are the minimum things that you do, and Brugada syndrome, that is arrhythmogenic ventricular problems. Then if the findings are not there, you may go for an echocardiography or confirmed by Holter monitoring. These are the basic investigation. In healthy patients with a classic history of vasovagal syncope, normal examination and normal ECG, no further testing is required. That is the take-home message we can consider. Anybody coming with syncope, two things you should never miss. One is ectopy pregnancy. Anybody in the fertile period, a lady coming with syncope, think about ectopic. Check the pregnancy test. And elderly coming, think about a GI bleed, because the patient may not say about the history of hematemesis or history of melena. They may just say that they collapsed in the toilet. Always remember these two conditions in addition to a patient coming with myocardial infarction. If the diagnosis is not obvious from the history, physical examination, and the ECG and monitoring, you may go for one is the special test, carotid sinus massage, tilt table testing, electrophysiological study, and loop recorder. So that is the special test. So today we have discussed about the definition of syncope, the common causes. We are divided into reflex syncope, cardiogenic syncope, and orthostatic syncope, and how to differentiate between syncope and seizure, and the basic investigations. Most important is a good history, proper physical examination to look for cardiac problems like aortic valvular disease, other valvular diseases, and a tailored investigation. Rather than asking for CT scan, MRI, and Doppler for all patients, when indicated, go for other investigations like CT scan when you're suspecting a seizure, or MRI when you're suspecting a vertebral basilar insufficiency, or a Doppler study when you're suspecting carotid problems or vertebral basilar problems. Hope it was useful to you. Thank you.